Welcome friends to our NPTEL MOOC module on health economics. I hope you are following this course very well, and in between we have already started discussing about the aspects of equity and equality. In the previous lecture especially we discussed about equity, vertical equity in different contexts. However, in this lecture we will be emphasizing on equity in distribution, and especially in the previous lecture we talk about equity in health financing, and also discuss the extent of vertical and horizontal equity, concentration curve, concentration index, then progressivity index, etc. And especially in the last lecture we used Kokoni's progressivity index to understand equity for the case of health financing. We discuss about concentration curve and concentration index. In this lecture again we will be emphasizing these two, and in addition to that we will also clarify vertical equity and horizontal equity. So, and these are all important because of specifying the equity in the context of distribution. Especially in the previous lecture I am just giving you a snapshot what we did it. We started discussing about horizontal equity where we discuss about ability to pay for health care, and where we mentioned that pay different amounts for it if have the same ability. And we also cited the case for social health insurance, and we mentioned whether that leads to better equity or inequity, especially in horizontal equity inequity case. If the household with similar incomes are members of different social health insurance schemes with different payment schedules, then horizontal equity is the possibility, and this might arise because they are in different occupation groups, but still they are receiving the same social health insurance schemes. In private health insurance scheme, people with the same income will pay different private insurance premiums if they have different risk status. And understanding the tax based system and its connection with horizontal inequity, we said that when it is of direct taxation, especially when if local taxes vary across regions, and then that is considered to be to some extent progressive. And in indirect taxation system, you will see that if same income group of people consume different amounts of taxable goods, then that creates inequity. Okay. In direct out-of-pocket payments, horizontal inequity occurs because of individual variation in the incidence of ill events or in ill health and the preference of use of healthcare services across people with the same income. So, there are different measures of horizontal inequity, especially in finance, mentioned by Aronson et al., and this is commonly used. And the approach horizontal inequity is measured by the variation in healthcare payments among groups of people or household with the same prepayment income or history or their level. In the case of taxes, when taxes are paid, and but the axes are actually different, okay, and variation in healthcare payments are there, and then the healthcare axis is again given. Basically, we are comparing with their income level with or without taxes. When it is with the same prepayment income or level of income, but the variation in healthcare payments are different, then that creates the possibility of horizontal inequity. And if no variation within each group, then of course we attend the person attains horizontal equity, and in case of variation that result inequity, horizontal inequity. Horizontal we refer to their income same level, same income level or status, etc. And variation in payments increased measured using the concentration index for payments, which we did it in the last lecture. So, CCPY, which we discussed, payments for given the income. We are referring to Doorslaer et al. 1999 emphasis and findings. They studied healthcare financing in 12 OECD countries and decomposed the overall inequality into majorly 3 parts. One is vertical inequity, then horizontal, and last one is actually called re-ranking component. Okay, so that's vertical inequity and horizontal largely we have discussed. However, in case of re-ranking component, the change is also emphasized with how the payment system affects whether the people have actually moved up or down the income distribution. So, that's called re-ranking component. In their findings, vertical inequity, they find it is important because difference in income were a more significant factor in explaining inequality in healthcare payments compared to other factors, whereas by variation by payment type, it identifies as tax based or social health insurance payments or through private health insurance or direct out of pocket payments, and tax based and social health insurance payments are relatively fair and has less horizontal inequity as compared to the private health insurance or direct out of pocket payments. Coming to the equity in distribution, once again, in addition to the equity in finance, healthcare is distributed to an equitable way. That is indeed a concern as we connect to the theory, the foundational theory given by Crossman in 1972. We discussed also in unit number 2 that healthcare services are demanded largely because of their effect on health. Hence, equitable distribution is a major concern. And so, the obvious question here is, should we focus on health or on making people happy when deciding how much to spend and how to share the healthcare resources? So, it is not just confined to the income, it is confined to other aspects such as to remain healthy, being happiness or well-being as part of better utility is important. Some scholars argue these contexts in terms of welfareism, that how people find happy, and extra welfareism, who are not just happy in the context of extra welfareism. Some suggest and argue that it is not just happy, you are also supposed to link with the health, so that both are actually are carrying together. So, if you are actually healthy, then you will be happy. If you are happy, you are also expected to be healthy. So, so this is how people present in terms of the issues of distribution. So, the equity measurement are mainly presented in 2 concepts. First, through horizontal or vertical equity or inequity. Then the second is more important, how we find empirically. Okay. And the extent to which inequalities in health vary systematically with socioeconomic status. And to investigate horizontal and vertical equity in health issue, we refer to positive analysis and sometimes refer to normative analysis. Positive, where we are actually trying to find out the cofactors or the factor determining health care services. Okay. This helps us tracking the status of people for their health care at the given time of their response. Whereas in case of normative one, it's really defining the core value of the distribution, where we are supposed to find out whether it is ought to affect or ought not to affect. When we say anything like an analysis which require to distinguish the factors which really affect by need or by non-need variables. Okay. So, the factors ought to affect the use, or the factors, the ones that ought not to affect. Okay, so broadly speaking, this explains need based and non need based variables. Hence, normative analysis helps us decide what regions are fair for need variables and which are not, so far as non need variables are concerned. Horizontal inequity, the factors, important factors in healthcare might be morbidity, age, gender, income, socioeconomic status, ethnicity, availability of healthcare services, etc. And typically the regression analysis use these variables and identify the factors which after controlling other factors which are relevant. Horizontal inequity, after considering all the factors. Okay, so after considering all the factors, if people with the same needs are getting different amounts of healthcare because of unfair reasons like income. It's like saying, hey, everyone who is sick should get the same care, regardless of how much money they carry. Okay, so there are two aspects of horizontal inequity again. One is the inequity which is pro poor and another is called pro rich. Okay, so far as pro rich is concerned, after adjusting for the need, if people gets, if rich people get more health care than poor people, that's called pro rich horizontal inequity. Yes, adjustments are made based on the factors which we just mentioned. If that is made and some adjustments are made, and but still it is making the rich more viable, or the making the rich more advantageous, or the rich people are receiving more benefits than the poor, that is called pro rich horizontal inequity. If the inequity is actually skewed towards the rich, then that is called pro rich, and the reverse is called pro poor. So, the factors like education is given with the hope that all will be receiving equal, but actually in case of universal health education scheme, but given the background characteristics, the rich students might be performing better. Similarly, other factors as well. Okay, coming to the identification or the measurement of those inequity, we are supposed to take the concentration indices, and that indice indeed quantify the extent of horizontal equity for actual and for needed health care. So, now question here is how the actual and needed are actually defined. We will also give you the practical handouts and or the hands-on experience in our next lecture. However, we are just measuring in this diagram about the cumulative proportion of need for the healthcare as against the cumulative proportion of the population ranked by their income. That means, with the higher the income by the population by quantile groups, if we do it, or by the by percentile groups till 100%, what happens to the proportion of healthcare need. Okay, so when we map it, we find it, we have used this term for MY and NY in the last lecture. It was on the need based need out of the income, or for specifically for the healthcare out of their income. So, two diagrams are drawn. Basic idea is the same as explained earlier. So, CCMY measures the healthcare concentration curve, and the shape of this MY CCMY measures the degree of inequity in the distribution of healthcare across income groups. Please note that if everyone receives the same health care, then CCMY, that is for the healthcare concentration curve, would be actually coinciding with the 45-degree line, okay, if it is equal. That means horizontal equity is maintained. If healthcare is concentrated among the rich, then or the poor, then it will be actually deviating from that of the line of equality. So, if it is biased towards the rich, then that line will be above the line of equality. When the concentration or the distribution is biasing towards the rich, then it is going to be below the line of equality. Okay. And if it is biased towards the poor, if that distribution is actually helping the poor, then it is in fact above that of the equality, line of equality. So, concentration index for healthcare, which we measured in the last class, we discussed in the last lecture. For the healthcare concentration index, it is just the twice of the size of the area between MY and the CCMY and the 45-degree line. You can just see this distance, isn't it? So, the twice of this area, and it is the optimum or the range of this index will be -1 to +1, okay. And again, if it is +1, all healthcare was received by the richest person in the population. That means all richest have actually received the population. And if it is actually just plus number, not plus in near close to 1 or somewhere positive numbers and less than 1, and if it is positive numbers, okay, then it is guaranteeing the fact that the distribution is actually helping the rich, okay, and richest are actually more benefited by the distribution. And if it is -1, just the reverse, and the poorer are the beneficiaries out of it majorly, and if it is 0, that means it is actually overlapping with that of the concentration curve, okay, or it is actually equally distributed between poor and rich population throughout the distribution channel. So, CCMY and CIMY, so that basically one is index, another I mean these indeed provide income related inequality in healthcare, and this gives very little about income related inequity, because they do not account for differences in needs for healthcare, because we only discuss about healthcare spending largely. But now when we track by their income, we are supposed to calculate the index based on their income with respect to their different level of income, okay. So, if poorer people consumed more healthcare, this is evidence of inequality in healthcare use, but it may not be inequitable if the poor may have greater needs. Wagstaff and Doorslaer in 2000 proposed measuring horizontal inequity in healthcare. You may prepare for the quiz, and these might be asked in the UGC competitive exam as well. So, coming to horizontal inequity, so HI, this is precisely the difference between the extent of inequality in actual use and inequality in use if everyone with the same needs are treated equally. So, the difference between CIMY and CINY, okay. So, these two even we have discussed in the previous lecture. So, this difference is largely called as identified by Wagstaff and Doorslaer. The CIMY minus CINY is measuring the horizontal inequity. So, CINY is based on predicted values, okay, since that is based on need, and usually these predicted values are derived through regression analysis, and we calculate maybe sometimes through their predicted values or maybe their expected value. So, the expected amount of healthcare a person would receive if they were on average treated as others with the same need characteristics. So, concentration curve, that is CCNY, plots the cumulative percentage of population ranked by income to the cumulative percentage of where all patients with same needs receive the same care. So, it is not just proportion, it is actually the cumulative proportion, hence the curve has an increasing trend. And the CCNY, which referred to the need expected or need predicted concentration curve, this is the one we have highlighted, CCNY. Okay. And CINY is the index that's based on the need expected or need predicted concentration values, that is the index. So, we are just presenting one case of Europe based on the figures of horizontal inequity in healthcare. So, they study the findings are on the healthcare needs and also standardized. In horizontal inequity studies, healthcare needs are controlled for using indirect standardizations. This involves a regression model using individual level data. So, this is how the regression model, which has taken the need variable as well as non-need variables. Okay. And this is precisely with beta coefficient, constant term, and the error terms. So, since we are emphasizing on the need based variables, so this part might be also added with the error distribution. So, M is precisely called the medical care to individuals of same need, and others I think I have already explained. N is a set of J needs indicator, and J is a set of K non-needs indicators. How they actually make it? So, testing for the statistical significance of the non-need variables and test for horizontal inequity is made. So, and there is horizontal inequity if that sigma value is none other than 0. Okay. So, so here we say that delta, which we have already mentioned, like alpha, beta and delta are coefficients, and this is what is actually mentioned. Okay. And if this delta value is actually non-zero, then there is horizontal inequity. Okay. So, alright. So, that means these M needs are actually not completely equalized with this, because there are non-zero component here as well. So, we will just clarify this. Indirect standardization for healthcare needs gives the need expected or need predicted level of utilization. So, this is what is standardized with the other indicator. We are just mentioning here that the expected amount is mentioned with its predicted notation, that M hat. The expected amount of healthcare a person would receive if he or she is or was treated in the same way as others with the same need characteristics on the average. So, the expected value, similarly we have also taken hat in every cases and controlling the non-need variables. The effect of non-need variables is neutralized to predict the impact of need on healthcare need based requirement for the healthcare access. Okay. And fine, I think I have already mentioned the concentration curve based on M hat, that is need expected or need predicted concentration curve, which is presented in the figure, and the regression model also be used to decompose inequality in healthcare use. Wagstaff et al. In their 2003, they decomposed by considering these variable, and however they have also just taken as a ratio by dividing the M medical care component. So, these when we say bar, if it is taken that represents mean values of m, n and g. Okay, m, n and g. So, Ci ny and Ci jy are concentration indices for n and j respectively. Gc divided by m bar is indeed called generalized concentration index for the error term. Okay. So, further details you can get it from the paper, and so this is indeed the decompose indicator of CIMY. So, one deterministic value is that first two terms on the right hand side of the decomposition equation equals to the weighted sum of income related inequality in the need and non-need variables with the weights given by the elasticity of healthcare used with respect to each of these variables. Others are actually random. Okay, so Doorslaer et al. 2004 again investigated the horizontal inequity in this generalized for this general practitioner case as well as for the specialized visits for the 12 European countries. So, and they derived some interesting fact, and they use the individual level survey data of those European Community Household Panel, and they derive these figures. When we say I mean these are for the European countries, they here we say general practitioner, the GP visits and the specialized visits. For it is observed that so far as horizontal inequity is concerned, you see that the figures are in minus. Okay, mostly are in minus, especially except even those are significant. Okay, at 5% level, and when it is minus, that means we have already given the indicator to +1 to -1. When it is towards minus, that means it is the distribution is favoring the poor, and when it is plus, that means the healthcare distribution is actually favoring the rich, or the horizontal inequity is actually in a distribution channel helping the poor. So, since it is minus for the general practitioner's visit or the general consultations, you see it is actually negative, that means the distribution is pro-poor. Whereas, in case of super specialist or the specialist visit, this is positive, that means those who can afford, they can access better, and the societal policy is actually favoring them more to access the specialist visits. So, the GP visits, the factors might be other socio-economic factors than income, whereas in case of specialist one, it might be largely due to income. So, these are all written. I think you can go through. We have already said here that the GP visits, role of education and retirement, non-participation in the labor force, etc. Whereas the specialist visits income may matter much. Okay, we have also discussed this in the context of vertical equity. This considers the degree of the individual with their level of income. Okay, and this considers the degree to which individual with varying healthcare demands utilize resources at suitably at different level. Okay, and higher levels of need usually represented by more or severe morbidity, because they used to have higher need. Okay, so this is necessary but not sufficient test for vertical equity. Authors also worked on vertical inequity like Soton and Basulu et al. Etc. You can just follow from other papers. Here are some guidance for you to understand factors of access to healthcare. Some of the works we are just citing like Penchansky and Thomas. They defined through the explanation called the degree of fit between individual and healthcare system. Okay, they include some of the important dimensions, 5 important dimensions based on age, 5 A's concept: availability, accessibility, accommodation, affordability and acceptability, whereas the author Maclean Toll in 2009 they mentioned about 3 dimensions that include availability, affordability and accessibility. However, the availability included other 3 subcomponent, okay, like accommodation, accessibility and availability. And Carillo etc. They in 2011 discuss about healthcare access barriers model. Another other modifiable healthcare access barriers are of 3 types. One is on financial, another structural and cognitive. So that's also present some forms of barriers we have discussed directly and indirectly. So you can follow from the readings if you are stuck somewhere, and in the next lecture we will try to give you hands-on understanding of horizontal equity. Okay, so that's all for today. Thank you.